Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Good evening and welcome to Direct Connection. Coming up tonight, a closer look at a coronavirus hotspot that is in a location in Maryland that you might not expect. That's ahead. First tonight, might it be a false dawn or perhaps a turning point in Maryland's battle with the coronavirus? Joining us is Dr. Cliff Mitchell, Director of Environmental Health Bureau for the Maryland Department of Health. Dr. Mitchell, thank you for being with us.
Nice to be here, Jeff.
I'd like to begin, if we can, with a graph that is on the excellent coronavirus.maryland.gov website. This shows the number of people in hospitals day by day around the state. The top line is the total number of people. The bottom line is people in intensive care, and the middle is non-intensive care. And folks looking at this on the right side can see a couple of dots that are lower than the day before, especially today's. Are we reading too much into this to think or hope that maybe this is a sign that things have peaked?
Well, Jeff, it's a good question. And, we're watching these data very closely. I think that you have to remember, we generally look at a number of days rather than just a couple of days. So we'd like to see something that's sustained over 5, 6, 7 days into 2 weeks to say that there's really a trend there. On the basis of 1 or 2 days, I'd be very cautious because we do see these numbers bounce around a little bit.
What else do you see in the numbers in terms of potentially flattening the curve? I mean, one takeaway, the top line, the number of people in the hospital around the state is right around 1,500 now. It had been as high as 1,700. But in a state with 7,000 or 8,000 hospital beds or more, it seems manageable. How would you assess it?
So, when this started, one of the things that the planners at the Department of Health, under the leadership of Secretary Neal and the governor, did was to look at what we could project if we had this pandemic occurring across the state. What might the projections be? So we looked at there were many models out there. And frankly, one of our concerns was looking at the experience in Italy and New York, across the country, at what happened in Washington state. And we were planning for potentially a surge of hospitalizations if we were not successful in slowing the spread. Everything the governor's done, and under his leadership, and the things that Marylanders have done, frankly, to isolate themselves, stay home, not do large group gatherings, has been the reason that we have not seen a kind of out of control surge of hospitalization. So it's really a credit to the people of Maryland and the governor's leadership that we're in a relatively good position right now in terms of managing the cases that occur.
What's your understanding today of how this disease spreads? Has there been any change in that in terms of it's through the air, it's aerosolized, it's inhaled versus being ingested or getting in your eyes or some other method?
So I think that the big realization that a lot of us have had in the public health community is some indications early on that there were perhaps people who could transmit the virus who weren't necessarily showing symptoms. I don't think that there was the appreciation for how many people carrying the infection might have either very mild symptoms or no symptoms whatsoever. What's become clear, certainly from surveys in nursing homes, but also looking around the world, is that the number of people who are infected is significantly larger than the number of people that we're testing. And a significant number of people may be infected and not know that they're infected. When that happens, what that means is that people are walking around even before they develop symptoms. They may be shedding virus and infecting a couple of people. This is the thing that makes this so difficult. Ordinarily, when you have a disease like this, if you develop symptoms, you have a relatively short window, but still a window where you can isolate that person, get that person into a closed environment, and protect the rest of the public from further infections. Here, what's clear is that there are a significant number of people walking around who either have yet to develop symptoms but are still shedding virus, or may not develop symptoms but are still shedding virus. And that makes it incredibly difficult to control the spread of this disease.
Let me remind our viewers, if you have a question about the coronavirus disease, you can give us a call. We'll have the number on the screen. You can also email your questions. The email address, livequestions@mpt.org. Dr. Mitchell, your background's in occupational health, indoor air quality, perfect qualifications to talk about what we as individuals need to do when we go to a grocery store, or people who are working at the grocery store, or other jobs that may have, say, a medium level of risk. What's your best advice at the moment?
Well, and I have to say that, there's been a lot of thought about this by a lot of people, but I will say wearing facial coverings is clearly an effective way of reducing the spread of coronavirus, both in public out at large and particularly in retail spaces where the air doesn't move as much, frankly, as when you're out of doors. So it really is important to keep that social distance of 6 feet or more, because that does reduce the number of especially large respiratory droplets that will travel to the person that you're talking to or that you're in front of. Keeping that 6 foot distance, really, really important. Just as important, having a facial covering. It's not so much about protecting you as about protecting the person that you're interacting with. So for people who work in retail, it protects them. And similarly, if they're wearing facial coverings, that protects you as a customer. So those kinds of things are really important. Frequent hand washing, absolutely critical. All of the things that we've talked about for cough hygiene and sneeze hygiene, barriers, as many retailers are now putting in, helps to prevent spread. All of these are really, really necessary. And then there are some things that, from an engineering point of view, you can do, such as increasing ventilation in your retail facilities. But frequent cleaning, hand hygiene, cough hygiene, social distancing, and facial coverings, those are things that are not sophisticated. They're not, they're not really high tech, but they're really effective if you do all of them.
Let's take a phone call. Allegheny County, this is Lisa. Lisa, thank you for calling. Go ahead.
Thanks for taking my call. I have kind of two questions. One is, everything I've read in the last 6 months on the antibody testing is based on the SARS-CoV-2 virus. Is that correct? And the second question is, what happened to viruses 3 through 18? Thank you.
Okay. Lisa, thanks very much.
Lisa, you're clearly reading a lot. So let me just go back a little bit. So SARS-CoV-2, which is otherwise SARS coronavirus 2, has been nicknamed by the World Health Organization COVID-19. It's the same virus. That's the virus that people are trying to do direct antibody testing to see whether or not people have been exposed and developed antibodies. And the challenge with that is that we don't really have a reliable, as yet, antibody test. So there are a significant number of antibody tests out there that people have developed, but none of them has been shown to be reliable enough that our state laboratory has recommended putting it into use, generally here in Maryland. It's not that the others are no good, but they're not good enough for public health purposes to understand what's really happening in communities. And that's the answer to your question.
Here's an email question. Anthony wants to know, I was a frequent user of the library system pre-coronavirus. wondering how long the virus can live on the various types of library materials, books, magazines, DVDs, cases, music CDs, and so forth. Should the library system be purchasing UV light equipment to disinfect?
Yeah, no, that's a good question. We've gotten that question a lot in various contexts. So this virus is, I would say, hardy, but not unusually hardy. That is to say, it can survive outside of its host, outside of the lung, in respiratory droplets on surfaces. And it depends on what kind of surface it is, and it depends on the humidity, and it depends on the ultraviolet light and the light generally. In most cases, if you are out of doors, that the virus doesn't last very long at all. If you're indoors, and especially if it's kind of a cool, just the right humidity, firm surface, it can last up to days. But if the library is closed, as it is now in most cases, by the time anybody goes back into it, all the virus that was in there when it was open, is going to be long dead. So no, I don't think that when the library originally opens, routine cleaning should be sufficient. If coronavirus is still around, it will be important in places like libraries to have regular cleaning, especially of high-touch surfaces. And that's something that we stress for businesses as well as other workplaces. As long as you're doing routine cleaning with an EPA-registered disinfectant effective against COVID-2, that should be sufficient in most cases. And so I'm looking forward to the day the library reopens as an avid user, but. I think for the moment, it's having people together clustered is more of a concern than the concern about infection from the books.
Back to the masks for a second. I don't completely get how me wearing a mask protects everybody else, but doesn't protect me at all somehow. But that aside, if I go to the store, I'm absolutely wearing a mask and making sure it fits well. If I go out for a walk in the neighborhood, not too many people around, I'm not wearing the mask. Is that reasonable?
Jeff, it's a really good question. And let me say this, we've gotten more questions about this than practically anything else. And I certainly understand how. So it's not that it doesn't protect you at all. It does protect you. But remember that these viruses consist of droplets that are very small and then really, really small. And the really, really small droplets can stay suspended in air for some time. And those droplets, those particles are so fine that the mesh of most cloth doesn't actually stop you from inhaling them. But the bigger concern is the larger respiratory droplets. And those, the cloth actually does a good job, especially the closer you are to the source of the droplet. So the reason it's protective of other people especially is it stops other people from being sprayed with that droplet barrage when you cough or sneeze. You are still protected to some extent, because you are also protected from other people's cough and sneeze, but to a lesser degree. And for those very, very fine droplets, the ones that can get through the mesh of the cloth, the most effective deterrent is actually space. So that 6-foot space is what protects you. But back to your other question about being out. Yeah, sorry.
Well, let me get to another phone call before I run out of time. Southern Maryland,
Sure.
This is Robert. Robert, thank you for the call. Go ahead.
Yes, thank you for taking my call. And the mask theory makes a lot of sense. I'm particularly interested in a nudist colony where we have a lot of outdoor activities. And
Robert, have you called on this one before?
No.
I think you have. Let's move on to an email question. This is from James. A lot of people over 50, doctor, have gotten the pneumonia vaccine. Perhaps 2 types of it. Do these make any difference potentially in avoiding needing a ventilator at some point?
Well, 2 answers to that. The first answer is I don't think we know. We don't have enough data to know the answer to that. But the second question is it might be protective in the situation where somebody developed coronavirus and then developed a secondary pneumonia, a bacterial pneumonia, there may be some protective effect from that vaccine, but probably not against the virus itself and the acute respiratory distress that it causes.
Very good. Dr. Cliff Mitchell, who is the director of the Environmental Health Bureau at the Maryland Department of Health. Dr. Mitchell, we appreciate your time. Thank you, sir.
Thank you very much, Jeff, and best to you and your listeners.
Likewise, and we will remind everybody, great information at coronavirus.maryland.gov, and Direct Connection continues right after this.
Can you tell us what you know?
Turning back now to the race for the White House.
The State Board of Elections voted Thursday to set up a new election.
It must be a very emotional day.
The world changed in the blink of an eye.
Children are at the heart of this story.
The county with the state's third highest rate of coronavirus cases can be found far from the metro areas. It's Wicomico County on the lower shore. Joining us now is Dr. Chris Snyder. He's Chief Medical Quality Officer at Peninsula Regional Medical Center. Doctor, thanks for being with us. Tell us, what are you seeing at your hospital in terms of patient trends right now?
Yeah, fortunately, we're seeing a little bit of a decline in hospitalizations. We're seeing a continued rise in the community, though, much like most of the other parts of the Eastern Shore. We actually own Nanacoke Hospital also, and they're our sister hospital up in Seaford, Delaware. And then we have Somerset County also with McCready Hospital. That was closed earlier this year. So all those feeders plus multiple other regional areas, we serve 3 states, and we've had a fairly big outbreak here in the last 3 weeks.
How well was the hospital able to prepare for that?
Well, pat ourselves on the back. We went from a 288-bed hospital to a 460-bed hospital in about 3 weeks. We had a wonderful team and community support for it. We opened up an additional 55 critical care beds that were all ventilator supported. We're a regional trauma center, so we can handle critical care and a lot of the regional higher end care that's needed for the shore. But we were in no way ready for this. We had a building that fortunately was built in the mid 2000s. During the Ebola timeframe. So we had a wonderful spot to build a negative isolation building, and we were able to increase about 150 med-surg beds also. And that was a godsend because we pretty much house all our COVID patients right now in that one tower. The rest of the house is segregated and is for the regular medical surgical patients.
And we've been told that's a big concern for patients in the community who have other health issues. Maybe acute health issues that need treatment, but they're afraid of going into the hospital and catching the coronavirus.
Yeah, that's, and a lot of people don't talk about that. It's, business as usual. Now, I'll give you our trauma drop because nobody was driving. Our volume of chest pain dropped for some god-awful reason, but the COVID volume went up, and that's a subject, but the regular patients still come, the folks with cancer and pulmonary disease and heart disease, et cetera. So we had to segregate them quickly. That was really very challenging the first 4 weeks of this whole process. And I don't ever want to go through that again, honestly. It was amazing to see the amount of communication and hourly changes that we made on the fly to help support and make sure, number one, the patients were safe, and number two, the staff was also safe because we couldn't afford having sick staff.
What have you learned in those weeks? How's the experience different from the standpoint of a patient coming in with coronavirus symptoms today versus a month ago, and also from the standpoint of your fellow doctors, nurses, other hospital staff in terms of how they're prepared to handle it safely?
Yeah, we're unfortunately becoming experts in the management of COVID. It's at first it was it was scary. Just frankly honest with you, I've been in practice almost 25 years and I've seen a lot. And this was something I never experienced. The first patient I saw, and I think every provider who can tell you the first COVID patient they ever saw, was quite an experience. Were you protected? Were you safe? Were you doing the right thing? Was it COVID? Was it not COVID? We had 5 days to wait for testing at the time. Now we're turning around tests in an hour. We're isolating folks. We're all protecting ourselves. We have outstanding teamwork, but it took 8 weeks of practice to get to that point. And, unfortunately, we have a new normal now, but we've gotten to a point where at least we're in controlled chaos versus total chaos, which is what it was about 8 weeks ago.
The factor that everybody points to when you ask the question, why Wicomico County, is the numerous chicken processing plants on the lower shore. You have a lot of people working tight conditions, close quarters, cold conditions. Is that where you think it's coming from?
Yeah, that was our trend here. We noticed it. The clinicians were noticing it in the ER through visits and consistent patterns, especially when you get 30-year-olds coming in a respiratory failure for no apparent reason. It was quite alarming, actually. We escalated that on a daily basis to our leadership, and leadership would communicate with the government, and the state would fortunately tried to help out as much as they could in the beginning, but eventually they got testing down here, and that's what we're doing community-wide now, and that's really helped make a difference. But that population, I don't think it's as much their work environment as it's the fact that they live in a very tight environment. You'll have 6 or 7 adults living in a very small residence. Unfortunately, they don't have a lot of money. They have lots of family, and they don't speak English in many cases. A lot of the Haitian and Spanish-speaking migrant workers that work for the poultry industry and are the front lines of our food industry were affected by this because of it. They travel in buses back and forth together from the chicken plant to their homes and residence. A lot of them don't have cars, so 6 or 8 of them will jump in a car together and go to work. So they just live in tight quarters, and this virus loves that. It just spreads from person to person and hand to hand and aerosol to aerosol. And I think that was our major problem. But we've gotten ahead of it with testing, working very closely with Delaware's governor and our governor, and they gave us the resources we needed to step up. And when they came, we took them. And we got them tucked in, and luckily we had the facility to do it and the staff to do it. So so far, so good.
When you release somebody, whether they're workers that in that industry or something else, they're maybe not requiring hospital care, but they may still need oxygen. They may need, future treatment of some sort. I don't know. Are they contagious? And where can you send them, especially if it's somebody who lives in a situation you described, maybe a multi-generational home with a lot of other people?
Yeah, it's a great question with a lot of open-ended answers because we don't really know. We don't know how long this virus sheds. We don't really know how long the transmission is there. We're not even sure if you're immune after you've had a severe episode of it, hospitalization, et cetera. So we're literally guessing based on educated guesses, and we're using resources like New York, China, Korea, literature, evidence, sharing collegial phone calls with folks who've already done this, and we're trying to steal and take as best we can and learn and get our community prepared for it. We've been working very closely since Governor Hogan opened up surgeries. We're doing that starting on Wednesday because we really need to take care of our non-COVID population. We have centers who've stepped up. We have a nursing home who became a COVID sanctuary for our sickest patients, and we had the nursing care to help us support that. We've discharged multiple patients who were on ventilators 30 days after that from this nursing home. We've had some great success stories there. We've had Salisbury University stepped up and gave us housing so we could put people in there appropriately, whether they were homeless or couldn't quarantine at home because of tight quarters or situations. And we have that. And Dr. Catherine Fiddler and our ambulatory pop health team did a wonderful job of staffing that and making that available for people if they needed it for that 14-day quarantine that we've been following through the CDC. And then finally, there's the home visits. So our home patient visits, our home care centers have all really stepped up and gotten us the oxygen we need for folks at home. And we're doing telehealth with those folks, and the community providers are calling them regularly and making sure COVID folks are home. But this isn't going away anytime soon because these people have chronic illness, and we don't even know the extent of it at this point. We're learning every day something new comes up that we have to modify or change to make sure that patient's safe and the community is also safe. And that's really a huge challenge still.
Chris Snyder's the Chief Medical Quality Officer at Peninsula Regional Medical Center. Sir, thanks for your time.
Thank you.
And coming up Wednesday morning, Direct Connection will be live on Facebook, talking to economist Anirban Basu. Marianne Scully, CEO of Howard Bank, will be talking about the economy, unemployment, where the jobs are going to be. You can join us on that on Facebook. You don't have to be a member of Facebook. Just Google MPT News and Facebook. That's Wednesday at 11 a.m. Now, for all of us here at MPT, I'm Jeff Salkin. Thanks for watching Direct Connection, and have a good night.
This program was made by MPT to serve all of our diverse communities.